when I was in Illinois, 38 years. She was referred to me by a dermatologist. Dermatologists used to refer a lot of patients with wounds. And this particular dermatologist started her on Viagra because she complained about a new onset pain, and vasodilation is what he thought, and gave her a script for Viagra and sent her to me. That is very clever, yes.
Michael,
So,
use that much? No. Because I've used it for other reasons besides the, and you can't get the insurance companies usually pay for it. So you could send them the script, but they usually won't, be able to.
Well, honestly, I mean, my use of that drug is the other name, Ravadio, and I use that in people who have painful scleroderma with ulcers.
Right. Yep.
And that's hard to get it paid for.
Yeah, exactly.
But I have to admit, I've never used it for a tibial.
Yeah. But yeah, you're right, Horacio. I actually tried to get a documentation of pulmonary hypertension in those patients to get that covered. You're right. But anyway, she was on that. She did not get routine medical care. Hardworking mother of 2, had 1 miscarriage, no drug abuse, but she was a smoker. And she was not getting routine medical care, did not have health insurance at that time. So this is what her leg looked like when I saw. It was pre-tibial ulcer, and we quickly got an ABI. And as you can see, the right side was completely normal there, with normal ABIs, normal toe pressures, normal PVRs. But on the left side, there was a significant drop from the brachial to the high thigh, from 120 to 90, and then it was no significant segmental drop. So basically,
well, let's stop. Let's take a little more time with this one.
Yeah.
So, Michael, what do you give us about your reading of that?
So if you're trying to make the case that this is an ischemic ulcer, then it would be an ischemic ulcer at an unusual location, right? Classic location is over a bony prominence distal on the toe. So there's only 4 things I can think of that make you have an ischemic ulcer at an unusual location. The most common one is atherosclerosis with trauma. So this woman gets up at night, walks to the bathroom, smacks her leg on the corner of a table, gets a cut, that gets ischemic.
So,
right?
so let's
So that's
stop at
the
each
most
one.
common.
So if you get that, I mean, I know how to look at transmit waveforms and try to predict toe healing, but up in this region, how are you trying to predict whether this should have healed or not?
Well, first of all, I'm not as good as you. I can't predict with anything whether something's going to heal anywhere, so I have no idea.
Well, they all heal after we open them up.
Well, all right. But I think in this case, if you're going to use PVRs, I'd look at that PVR below where the ulcer is, right kind of at the ankle, and say, gee, that's going to be a plus minus. That's a flip of a coin.
Right.
So that's one, atherosclerosis with trauma, most common one. Second one would be atheromatous embolization. So if she had a cath or had a radi aorta and embolized distally, but you'd expect there to be other physical findings of that. The third one would be vasculitis. So a small vessel vasculitis would be the most common one that causes. And then the last one would be a brown recluse spider bite. So someone who's gone camping and doesn't remember if they got bitten. Those are the only 4 things I can think of. It's not a hard differential to go through.
And it's a very atypical looking ulcer.
It is.
It's got some hyperpigmentation to it, but it looks like it has some granulation tissue at the base, so it doesn't look like a classic arterial ulcer. I mean,
So if you were going to put your bet down on what you think that is, not knowing anything else about what Raghu said, I think the violaceous appearance at the edge of the margin of the ulcer is the key.
that's right.
It's a vasculitic ulcer, is what I would put my mind.
So there we were, okay. So the level of lesion from non-invasive is basically inflow disease. The other thing about the other differential diagnosis, Michael, do you want to point out the absolute normal?
Something like that.
She did, as you can see, Michael, that's, there's not atherosclerosis, it's completely, like a DVT looking thing.
So this is most likely giant cell Takayasu, something like that.
Okay.
I'd have to think. Leg, right?
yeah.
It's rotted.
I'm thinking antiphospholipid 2 at this point.
She could be, embolizing.
Inside
I guess.
So That was actually highest on my differential as soon as I put my, probe on the carotid. Anyway, so I quickly admitted her to the hospital, right? And thinking
Let's stop
about,
1 second. Let's give the audience a chance to jump in with any questions, comments, thoughts. Following us okay, what everyone's thinking? Anyone? Come on in, sit down, everybody. You don't have to stand out there. We got plenty of seats. Okay, Raju, go ahead.
All right, so we talked about differential. I did not have anything else other than antiphospholipid. Then I ordered baseline labs, started heparin, and I said, let's just monitor the anti-10S because I wasn't sure, and called my interventional colleagues and set up an angio of the leg. So the labs come back, baseline PTT was 42, and the baseline INR was 1.6. So now the antiphospholipid antibodies
moving up the top,
right? So
to climb up the line.
And then the concomitant things, mild thrombocytosis. She complained about chest pain, and we got a CT, and it was negative, no PE. And then antiphospholipid workup was sent off. Typically takes about a week for everything to come back. So angio here. Anybody want to comment on that?
So, she's got a flush left common iliac occlusion, but the weird part is it comes back 2 centimeters above the hypogastric origin, and usually when it's from atherosclerosis, it's going to be flush on both sides or just have a little nub, but not a long channel on the bottom side. I mean, her external on the right is also small and not normal looking. The left side's smaller, but that just can be from lack of pressure due to inadequate inflow. I mean, normally, if this lady didn't have that ulcer and all those other labs, most of us would probably be saying, "Oh, quick stent time. This would be in and out." But now, when you're still worried about this lady having antiphospholipid antibody, I want to see other places on her, and I'm not going to run. This might be usually a diagnostic angiogram, some anticoagulation until you have a little more interventional knowledge and what else is going on, because sometimes in these patients, they continue to thrombose when you start touching them. So
correct. But then you have to admit that's also funny looking for an area for thrombosis, right? That's not a classic spot that you would see it looking like that.
But on the other hand, we don't see any lumbar asymmetry here.
No, you don't.
And we don't see any suggestion that this is some chronic athero.
No. But I'm thinking
of
arteritis.
I hear you.
Yeah. Right.
So, and subsequently, we got an echocardiogram, and there was nothing in the heart. And it would be a weird place for the clot to go land in the
saying.
Yeah. So we thought, at this point, with the violaceous borders, antiphospholipid, the thought process, and everything else, the stroke, it all matched to APLA, and we thought this was in situ thrombosis as opposed to embolic event. So let's see, further below. So there is the popliteal. And I'll again shrink.
So a normal looking SFA with an abrupt close.
Again, flush occlusion of the popliteal just above the knee, or distal SFA in the adductor canal. So at that point, what our team decided at that point was to just angiojet the iliac and leave the popliteal alone at that point, see how the inflow would improve the ulcer, although I had my own thoughts that might not heal because it's mostly microvascular if it's antiphospholipid. But anyway, this is the highest anticardiolipins I've ever seen in my practice, 440 GPL. Beta-2 glycoproteins were in the 500 range, and the two inhibitor tests, the dilute vessel vipermenin time and the hex phase, were prolonged and did not normalize. So this is as positive as it can get for antiphospholipid antibody syndrome. So, not every antiphospholipid antibody syndrome patients require, Lovenox treatment or enoxaparin treatment. So I bridged her to warfarin with an INR of 3.2, and then she was discharged. Pain was controlled with Ultram. 10 days later, she comes back, and this is how the ulcer is looking now.
Wow.
Michael, got anything to add therapeutically?
I mean, I think you can put whatever you want on there.
And it's not going to help. Right. So what?
So again, we thought maybe the popliteal intervention would help at this point, right? So the angio showed iliac artery was not totally occluded, like Sean said. So that's when I learned to respect the clot. So that was recanalized, and they stented the popliteal artery. Labs were unchanged. INR on the day she clotted was 3.7. So she technically failed warfarin therapy, right? So I switched her to Lovenox, titrated her anti-10A to 0.75, and then sent her home.
So wait, let me ask Michael. So this is an extreme case, right? Highest thing Raghu's ever seen. Is there anything, I mean, we're getting the sense that this is almost crescendoing in some way, and not a good way. Is there anything you can think of out of the box that you could do to help this situation at this point?
I think the only thing you'd think of is this a primary antiphospholipid antibody syndrome, or is it secondary to some other systemic disease?
And all of that workup was negative.
Yeah, but I mean, had it not been, say, lupus or something,
Yeah, right.
you'd
Treat
go
the
after
underlying-
that aggressively, right?
So all of those were negative,
And is there a role for some of the novel oral anticoagulants over Lovenox therapy? I mean, you know, I know we probably still use Lovenox therapy, but do you think there ever will be a role for?
well, there are two trials ongoing, one for Eliquis, one for Xarelto for antiphospholipid antibody, but none of the Einstein, Amplify, or any of those patients or edoxaban trials included antiphospholipid. They were thrown out. So there's zero data on these patients.
Yeah, we wouldn't do it.
Yeah.
I guess so. What I was thinking is she's failed one. We're going to try another anticoagulant. She's got there's nothing crazy off the box.
So some hematology literature will, at this point, recommend corticosteroids,
Okay.
and because this will be sort of catastrophic antiphospholipid, but it's not been there yet. So, and the other thing is plasmapheresis. There's literature for that too. But we called hematology at this point, you know, to see if they would recommend that. They said she's not catastrophic, and we don't want to do that. So.
And the drawback would have been, I mean, I'm thinking, what a somewhat benign medication overall.
Well, steroids might not have been such a terrible idea.
Yeah.
No, that's what I mean. Why would you?
But plasmapheresis is not.
No, I got that part, but
Yeah.
the steroids.
What they said
tell
is-
me no, I'm always like, yeah, why not?
So Gary, what they said is, you know, she failed Coumadin. Some of these APLA patients will fail, so why not try the Lovenox and see how things go?
Okay.
So
What's the etiology of the extra iliac on the right that's abnormal?
No, I listen. I still think I still am confused about how this case is going. To be honest with you, I am. I think this is a really bizarre case.
Because she doesn't look pure.
Right. Now that external on the right looks vasculitic.
Vasculitic, you're right.
What did the left common iliac artery look like when they got the clot out before they stented it? Did it look normal?
They actually IVIS'd it. Other than the small caliber, there was no vessel wall thickening or anything like that. I was in the cath lab for the whole, procedure. So it was one of the most bizarre, probably the most bizarre case I've seen.
It is
in my
really
career.
bizarre.
So
You
4
know,
weeks.
the other question people will have is, you know, should you lyse these people? And, you know, in the setting of antiphospholipid antibody, you can get them open, but they commonly rethrombose on the table. And so when it's clot for other reasons and it's fresh, it works great. But the alpha patients, I've not had great experience with thrombolysis with. And so, you know, I think the mechanical, I think it's a great idea. But the problem is that once you touch that vessel, it is not a happy camper.
It gets pissed
Did
off.
she have a sed rate or anything like that?
Acid rate was elevated, but she had
all the other
thrombocyte
stuff.
with all the inflammation. Yeah. So she came through the ER. I was not in town, so my partners took her to the cath lab because of severe pain, and the iliac stent was open, but the popliteal stent was thrombosed. So my partner called me, and he started, profanity that he has never heard, and never seen the stent clot on the table like that. I had to correct him that my kids were in the back, so. But anyway, so she clotted off right in front of him, like you said, Sean. So now the platelets are 150, and that's the first thing I asked, because then she ended up having Lovenox-related hit.
Wow.
How many things can go wrong with this poor lady, right? So basically, the stent is occluded. Now what? So summary, she's 40 years now, 2 kids, husband doesn't work, and she has antiphospholipid antibody syndrome. I even checked her urinary creatinine levels at that time, and she was not smoking. Failed warfarin, now hit with enoxaparin. Severely painful ulcer, no insurance.
Fondaparinux.
Yeah. So that's what we did. Initially, treated her with argatroban, and then switched her to fondaparinux indefinitely. So that's what we did. Medicaid qualified, wound care, and I did some literature search. There were a few case reports of hyperbarics helping because of the small vessel issue, and I got dermograph guys to donate me some dermographs, and after 40 hyperbarics, she healed.
That's awesome.
Yeah.
That's great.
Yeah. So 6 months later, she comes with another ulcer. It's apocalypse, remember? So she's still on fondaparinux, still abstinence from smoking, aspirin and fondaparinux. Now she has 2 ulcers. So again, we referred her to vascular surgery at that time for a TOAMP versus popliteal bypass. After hearing this story, the vascular surgeon didn't want to touch her. So
She sent her to Cleveland.
Yeah. We're dumb enough to do it.
So partial TOAMP, and then got the hyperbarics again approved, but she had successful healing.
Now, is she limited from ambulation because of the popliteal occlusion? I mean, is she still able to work? And do
Yeah.
I mean, if you look at that foot, though, there's going to be more ulcers.
Yeah,
There's dependent
absolutely.
rubor, it's pallor, you hate giving up on those people. You get that amp to heal with HBO, but
Which
that
is
doesn't
amazing,
fix
by the
the
way.
problem.
I mean, just looking at that foot, not even looking at a PVR, I can't believe a toe amp healed.
I
Even
can't
with
either.
5,000